the Department of Health and Exercise Science at Gustavus, has been a member of this committee, and Dr. Russell will be introducing our next speaker for us. So, Dr. Russell.
An exploration of cancer in the age of biotechnology would be incomplete without an examination of disparities and inequities along with their possible solutions. Dr. Chanita Hughes-Halbert, a psychologist and medical researcher, is at the forefront of addressing these questions. Her work focuses on understanding how healthcare inequity, particularly racial inequity, shapes cancer risk and outcomes. Dr. Hughes-Halbert has examined interventions to increase African American women's participation in breast cancer screenings, community-based programs to help patients navigate the healthcare system, racial disparities in quality of life after cancer diagnosis, and the impact of stress on disease progression in African American men. Dr. Hughes-Halbert earned her undergraduate degree at Hampton University and her master's and doctorate degrees at Howard University. She is now professor in the Department of Psychiatry and Behavioral Sciences and Smart State Endowed Chair in Cancer Disparities at the Hollings Cancer Center at the Medical University of South Carolina. Prolific in the field, Dr. Hughes-Halbert's work has been funded through the National Institutes on Minority Health and Health Disparities and the National Cancer Institute. Among her many accolades, Dr. Hughes-Halbert was appointed by President Barack Obama to the National Cancer Institute Board of Scientific Advisors. In 2018, she was awarded the Distinguished Lecture on the Science of Cancer and Health Disparities by the American Association for Cancer Research. Additionally, she's been elected to the National Academy of Medicine. Dr. Hughes-Halbert's work is groundbreaking, exemplifies interdisciplinarity, and focuses on community engagement and strategies to reduce disparities. We are thrilled to welcome her to Nobel Conference 56.
Good afternoon. I'd like to thank the conference organizers for inviting me to participate in this exciting conference and for the opportunity to discuss transformational research in cancer health disparities. Now, cancer health disparities has been the focus of my academic career, but this has been a focus of empirical investigation for at least the past 2 decades and continues to grow in terms of its breadth, depth, and impact on our population's health. Now, cancer health disparities refers to differences in cancer risk and outcomes between individuals from diverse racial and ethnic minority groups when compared to non-minorities. When we think about cancer health disparities, the focus has been on understanding differences in cancer risk factors and outcomes between individuals from minority and non-minority groups. And these first and second generation studies have been critically important to providing the empirical basis and documentation of the nature and distribution of how racial minorities differ from non-minorities in terms of cancer risk and outcome factors. Now, consistent with the overall goal of translating research findings into action, research is now being conducted to evaluate the effects of intervention strategies on cancer risk behaviors such as cigarette smoking, obesity, and access to health care. Now, in many ways, these first and second generation studies were transformational because they radically changed our understanding of minority health and health disparities, and has led to the creation of a new paradigm for addressing racial disparities in cancer outcomes. Now, as the field of cancer health disparities has matured, so has our thinking and conceptualization of the factors that contribute to disparities. As shown in this figure, it is now widely recognized that biological, behavioral, environmental, and system-level factors operate at multiple levels of influence to influence cancer health disparities. My goal during the presentation today is to provide examples of where we are now in terms of our understanding of how these factors shape cancer health disparities and where the field is going to develop, implement, and disseminate interventions that can promote cancer health equity. So one of the ways in which cancer health disparities research has been transformed is through the focus that has been placed on working collaboratively with community-based organizations and other types of stakeholders to design, implement, and evaluate interventions to improve healthcare and outcomes in racial and ethnic minorities. So I want to tell you a little bit about an academic community partnership that I developed while I was on the faculty at the University of Pennsylvania, and it was called the Triumphant Living Collaborative, which was established with funding from the National Institute on Minority Health and Health Disparities to develop infrastructure for academic researchers and community-based organizations, as well as community residents, to work collaboratively to develop interventions that address disparities in health promotion and disease prevention among African Americans in the greater Philadelphia metropolitan area. To do this, one of our goals was to identify and prioritize health concerns and issues, and to translate that information into interventions that would be developed, implemented, and evaluated collaboratively by the partnership. We also had a goal of developing resources to help both academic investigators to be more effective in working collaboratively with community partners, but we also wanted to develop community capacity to be equally able to be effective partners in an academic community partnership. Our last goal for the partnership was to develop and implement interventions, strategies for disseminating the results of interventions to academic and community stakeholders. And I think this was a really important component of our partnership because we recognized early on that it was important for us to tell our community stakeholders, tell our community what the findings from our research were, but also to have an opportunity for residents to participate in an education process that didn't involve them really participating in a research study per se. So we had a really vibrant, robust community information workshop program that was designed to disseminate findings from studies that were related to health promotion and disease prevention beyond the specific work that was being done in our partnership. And this was a way for us to address health concerns that had been identified as priorities among our community residents. So this graph here is showing you the members, the academic and community organizations that were involved in our partnership. I want to point out a couple of things that I think are really important to know about how the partnership was developed. So first, while it did include academic organizations, first the University of Pennsylvania, and then later on in our process, the Medical University of South Carolina, it also included community-based organizations that were had a strategic mission and focus on health promotion and disease prevention, but provided the expertise and capacity to expand our breadth and depth to improve our ability to address community concerns. So, for instance, the National Black Leadership Initiative on Cancer is a grassroots organization that focuses on developing community education programs and developing collaboratively with other grassroots organizations as well as academic medical centers. The Health Promotion Council of Southeastern Pennsylvania is another type of community-based organization that had expertise in health education, health promotion, and service delivery and communication sciences. And so collectively we all brought I think a really different types of expertise to the table to help us and enable us to address, first to identify community concerns, prioritize them in a equitable way, and then develop interventions and solutions to address those concerns, and then work collaboratively to address them. So we were, one of the things I think is important to acknowledge is that the NIMHD, or the National Institute on Minority Health and Health Disparities, was really forward thinking when they established their community-based participatory research program. So they set it up in 3 phases, and the first phase was focused on developing the partnership, and this was a 3-year phase that where we were charged with identifying community health priorities and developing and pilot testing interventions to build the evidence base for conducting larger scale randomized trials, which was the focus of the second phase of the overall program and the second phase of our Triumphant Living Academic Community Partnership. So with funding from the NIMHD, we conducted a comparative effectiveness trial of risk education. We also received funding from the NCI, or the National Cancer Institute, to conduct an observational study that examined the effects of a community-based navigation program for cancer control. And then we also received funding from the Agency for Healthcare Research and Quality to disseminate information about breast cancer prevention using a community information workshop program format. And then the third phase, which was a 3-year period of time, focused on disseminating the results of our research to community stakeholders. And for this initiative, for this component or this phase, we didn't limit participation to individuals who had participated in our research studies. We really cast a wide net and opened up our community information workshops to the larger Philadelphia area. And we also worked with our community-based organizations in the Philadelphia area to implement the interventions that had been evaluated as part of our comparative effectiveness trial. So this is what we found. And this slide first shows you the outline and the layout for our comparative effectiveness trial. One of the things we learned in our first phase was that community residents were first concerned about cancer and cardiovascular disease and wanted interventions that would help them to live a healthier lifestyle. So community residents were not interested in a weight loss program. They didn't want to have to come into an intervention or a program where they had to be weighed, and the expectation was that they were working to lose a specific amount of weight. Rather, our community residents told us through our focus groups, key informant interviews, and a community health survey that they wanted interventions that would help them to live a healthier lifestyle while being more physically active and by eating a healthier diet. That led us to focus on developing a risk education program. And the rationale for the risk education program, which was developed under the leadership of our community partners from the National Black Leadership Initiative on Cancer and the Health Promotion Council of Southeastern Pennsylvania, was that there were opportunities to help people understand the connection between risk factors for cancer and cardiovascular disease, help them understand the overlap or the shared risk factors that exist between those two conditions, and that if individuals ate a healthier diet, if they exercised more, then that would have implications for their risk of developing cardiovascular disease and would also have implications for their risk of developing some forms of cancer. We developed or thought of this idea that this would be an important motivating factor because as we were doing our focus groups and key informant interviews, what became clear is that some residents sort of saw the connection between risk factors and was using that as sort of a motivating motivation that motivated them to want to be healthier, and it motivated them to want to be more physically active and motivated them to want to eat a healthier diet. At the same time, we also saw that some people didn't really see the connection, and so we thought that our hypothesis was that if people sort of understood the shared risk factors between cancer and cardiovascular disease, which was covered as part of our integrated risk education program, it would lead to an aha moment, and it would result in an increased engagement in eating consumptions of fruits and vegetables, and it would also increase their physical activity level in comparison to risk education that really focused just on helping people to understand risk factors for cardiovascular disease. I also want to point out that, as you can see here, there was a 4-session protocol, and in developing the number of sessions for the interventions, we made some strategic decisions, which one was that we're thinking about the long-term ability to disseminate the risk education program to community-based organizations. And an important feedback that we received along the way as we were developing the risk education protocol, and this feedback was from our community partners, was that we needed to be mindful of how long and the amount of resources that it would take for a community-based organization to implement any type of intervention into their service delivery and into their practice. That led us to develop a brief but intensive risk education protocol. Brief in that it was only a 4-session protocol. Intensive because it covered a significant amount. I think a lot of information was covered in each one of these sessions. So in addition to providing evidential content or content that was specific to disease facts and figures for African Americans, as shown in session 1, each session incorporated concrete, tangible strategies, evidence-based strategies that individuals could implement to change their behavior as it related to being more physically active and eating a healthier diet. I should also point out that as I've mentioned, the protocols were developed under the leadership of our collaborators from the Health Promotion Council of Southeastern Pennsylvania, but there are a lot of expertise at the table that really shaped sort of the content of the intervention protocols. One of the things that we paid particularly close attention to was ensuring that, in addition to including some of the components of motivational interviewing, we also delivered information that enabled people to really act upon the changes that were the behavioral strategies that were recommended as part of the intervention. So one example, Philadelphia is an urban area. There's a trolley system, there's a bus system, there's a subway system, and one of the things that we included as sort of making more active choices were examples such as participants could get off the bus at a couple of stops before where they would normally get off the bus to go home or go to work, and walk the extra way. So it was really tailored to the geographic opportunities to be physically active and lead a healthier lifestyle that were sort of within the context of the Philadelphia metropolitan area. So we enrolled 530 community residents from the greater Philadelphia metropolitan area into the comparative effectiveness trial. And there are a couple of things I want to point out that I think are really important. So first, participants were recruited using a community-based strategy that consisted of self-referrals from newspaper advertisements and flyers. Participants, initially, we limited participation to residents who lived in the West Philadelphia community. But as we started our recruitment activities, individuals from the entire Philadelphia area self-referred and were interested in participating. Our initial decision about limiting participation to specific zip codes in the Southwest Philadelphia and West Philadelphia area was because our partnership was really focused on that community, and we felt like that because it gave us more specific and precise geographic boundaries. But as we started recruiting for the study, and there was interest among individuals who lived across the entire Philadelphia metropolitan area, it became clearer. Our initial thought process became less important because, we started to get questions from individuals like, well, why can't I participate in the study? I don't understand why I can't participate in the study just because I don't live in the West Philadelphia community. So that led us to expand our geographic catchment area for the study to include the entire Philadelphia metropolitan area. The second thing that I think is important to acknowledge and just to point out is that 43% of our sample were men. And this is important because typically men are less willing, have lower enrollment in health promotion and disease prevention trials. And using our community-based dissemination strategies, and the selection of those were informed by our staff members, one of whom was a lifelong Philadelphia resident who was a man, who helped us think about the best places to distribute flyers, helped us to think about the best newspapers to advertise, to place study advertisements to reach a more diverse community sample in terms of the ratio between men and women. The other things that I think are important is that this research was done and conducted during the recession of 2008. So, many people were not employed and had an income that was less than $20,000. And even though 78% of our participants had health insurance, most of those were covered through a state or government-sponsored insurance program. The other thing that I think is important to note is that the body mass index, the average body mass index, was at the right up under the obese low category for being obese. So, these are participants who, I think where weight loss would be an important goal. But again, consistent with the priority and the preference for an education program that really didn't focus on weight loss as a specific outcome. It really focused on helping people to live a healthier lifestyle. I think is really important to just acknowledge that we honored that, even though we saw that the average body mass index was pretty high. So what did we find? Well, first, I just want to point out that we had, I think, a really high level of intervention completion. This is a really important metric because it helps us to understand and identify any potential biases associated with the ultimate effects of the intervention. And there were 73% of participants were intervention completers, which meant that they completed all 4 of the intervention sessions. I should point out that one of the decisions that we made is that it was important for us to provide individuals with resources, financial support to come to the session. So they were given a $20 stipend to pay for childcare, to pay for transportation. And that was one of the features of our study protocol. There are also no difference in intervention completion based on whether or not individuals were randomized to the integrated or disease-specific counseling, and there were no differences in intervention completion based on traditional socioeconomic or socioeconomic characteristics or body mass index. So our primary outcomes were fruit and vegetable consumption and physical activity, and these were measured in terms of whether or not individuals met the recommended guidelines or did not meet the recommended guidelines. And what we didn't find any significant effects in terms of changes in the proportion of participants who met the recommended guidelines for fruit and vegetable intake, but we did find significant increases in the proportion of participants who met the recommended guidelines among those who were randomized to the integrated risk education group. This shows the logistic regression model of our physical activity outcome, which basically shows that after you control for variables that were associated with completing the 1-month follow-up interview, and this logistic regression model is based on our 1-month outcome data, is that there are no differences between the intervention groups, but that it was whether or not individuals completed the intervention sessions, all of the intervention sessions, and their education level, which I think is really important, because one, it shows that all things being equal, we have two protocols that can be effective at producing increases in the likelihood of meeting the recommended guidelines for physical activity. It also tells us, though, that completing the entire protocol is really important, because, you know, and I think this applies to any type of behavioral intervention. You know, we design our behavioral interventions to provide information in a sequential way that builds upon and reinforces the previous content. And so this held true for our study, and that participants who completed all 4 sessions were had an increased likelihood of meeting the recommended guidelines for physical activity after controlling for other variables as shown here. The other thing that I think is important to acknowledge about this program is that we, as I've mentioned earlier, we did pay particular attention to incorporating evidence-based strategies for eating a healthier diet and becoming more physically active. And I think one of the reasons why we saw increases in the proportion of participants who met the recommended guidelines for physical activity is because many of them actually use the behavior change strategies that were described and relevant for physical activity more so than for dietary behaviors. And what I'm showing you now are the percentage of residents who reported that they started a walking program, the percentage of participants who said that they started a walking program, made more active choices, and talked to a healthcare provider about their concerns, or exercised in short bouts following the intervention. So you can see that it was fairly high in terms of the likelihood, the percentage of participants who performed those behaviors. And then finally, we also, because this was an academic community partnership, and the ultimate goal for, I think, any community-based participatory research program is that it actually targets and addresses community concerns. And what you can see here is that overall participants said that the interventions addressed their concerns about physical activity. It addressed their concerns related to vegetable intake and fruit intake. You can also see that there was a high level of engagement in terms of participants reading the intervention materials, and participants were also very satisfied with the health educator, her ability to explain issues, and the convenience of participating in the sessions. I think, you know, if we had to do it over again, we would probably reconsider the number of sessions that were offered, based on 64% saying that they were satisfied with the number of sessions that were delivered. I think what we heard anecdotally after the intervention was completed was that participants really wanted more time to be together, wanted more time with the health educator, because the information was valuable, what was important, and they enjoyed interacting as part of the group sessions. So this summarizes some of our key findings from sort of this community-based participatory approach program. And one of the things I think is a key take-home message that continues to inform the field today is that we need to have ongoing engagement of diverse stakeholders from the community, and we need to incorporate participatory strategies in our efforts that are focused on promoting cancer health equity. Which is really why I think this has been one of the focal areas in the All of Us research program. So community engagement is an underlying or foundational value within All of Us because it emphasizes active participation among diverse stakeholders to work to identify ways to implement strategies that can ensure the diversity of participants who are enrolled in the All of Us research program. And I think the precision medicine has really, the precision medicine initiative has encouraged us to think beyond the clinical strategies to efforts that enable us to deliver the right intervention at the right time to the right population. So we're sort of moving from sort of this precision medicine, which is really focused on, a clinical application of individualized strategies, to this precision public health approach, which is thinking broadly and reaching the population. And we can think about African Americans and racial and ethnic minority groups as sort of different populations that can be targeted as part of precision public health strategies. One of the ways that we can think about this within the context of cancer health disparities is from the perspective of diseases such as lung cancer, in which national data continue to show that African Americans are an important population for precision health interventions that can be used and employed to address risk behaviors such as cigarette smoking. So consistent with this, precision prevention strategies for lung cancer emphasize early detection through lung cancer screening, tailoring pharmacological strategies according to smoking-related biomarkers, and identifying the most effective ways to deliver smoking cessation interventions. These approaches have significant promise, but African Americans were underrepresented in the National Lung Cancer Screening Trial, and limited efforts have been made to develop smoking cessation programs that are targeted to the smoking behaviors and patterns among African Americans. So this has raised some, I think, important concerns about the potential for precision medicine and precision prevention or precision public health to exacerbate cancer health disparities. And when we think about and one of the ways that this concern is being addressed is by developing conceptual frameworks that have greater precision in terms of specifying the mechanistic pathways that are potentially important to racial disparities and cancer risk and outcomes. Now, this first model that I'm showing you here, which was developed through the Centers for Population Health and Health Disparities, is important because it was one of the first to identify determinants of disparities beyond health behaviors, psychological characteristics, and genetic factors. And it really sort of pushed us to sort of question how social conditions sort of contribute to how social conditions, health behaviors, and biological factors contribute to minority health and health disparities. And so we kind of have this sort of linear organization of these variables is all kind of each having their, their singular contribution to minority health and disparate health outcomes among racial and ethnic minority groups. We now have conceptual models that have greater precision, I think, and offer greater explanation about the potential mechanisms and pathways and how these stress pathways, physiological and behavioral reactions, and genomic pathways can contribute to racial disparities in cancer outcomes. So we're now becoming more, I think, precise and more mechanistic in beginning to think through and understand the pathways that are important to racial disparities in cancer outcomes. I want to spend the last few minutes talking about our center, our Precision Medicine Center, at the Medical University of South Carolina, which is a transdisciplinary collaborative center in precision medicine and minority men's health, as one example of how this sort of the mechanistic model, this more pathway-oriented model for cancer health disparities is used to address precision medicine and minority men's health. So our group has, and as others, have really been focused on understanding prostate risk and outcomes because it continues to be one of the leading causes of cancer among men. African American men continue to have greater incidence from prostate cancer and have significantly continue to have greater morbidity and mortality from this disease. Our group has worked to understand determinants or racial differences in quality of life outcomes and other psychological reactions to being diagnosed with prostate cancer, as well as understand screening behaviors. And one of the things that we found consistently was that perceptions of stress were important to men's quality of life, their emotional well-being, their physical well-being following their prostate cancer diagnosis. Perceptions of stress were also important to how men responded to being diagnosed with prostate cancer. And so this really sort of began to generate questions for us about how psychosocial stress is a potential pathway through which that's important to the initiation and progression of prostate cancer, and can also be an important variable in how men respond. As you can see in this figure, our Precision Medicine Center is exploring and examining several different ways in which stress can influence racial disparities and disease processes among African American and white men. Now, stress is a multidimensional construct, and our center is examining stress as a social determinant and as a physiological response that influences disease outcomes. Our conceptualization of stress as both a social determinant and a physiological response was influenced by the unique stressors, unique acute and chronic stressors that African American men experience on a daily basis, and previous studies that have shown that social and psychological stressors impact processes that are important to the initiation and progression of disease. Our decision specifically to use allostatic load as the overarching physiological framework and biomarker in the center is because it is a marker of how much social and psychological stressors impact biological functioning. Several studies have shown that African Americans and whites differ in terms of allostatic load, but within the context of racial disparities research, minority health research, and cancer health disparities research in particular, there's been limited attention to the ways in which allostatic load are associated with psychological responses, behavioral responses, and the biological processes that are important to the initiation and progression of disease. This led us to focus on developing a better understanding of the effects of allostatic load on disease processes and outcomes as part of our center. Amen. So our overarching question for the center is is really trying to understand how psychosocial stress influences cellular stress response. I think it's important that this work is being conducted in South Carolina, where this state, my state in particular, I think really reflects the broader social context and geographic challenges that exist across the country. As you can see under the project descriptions, all of the studies focus on prostate cancer and a critical clinical time point within the trajectory from diagnosis to treatment. So Project 1, for instance, is examining stress responses and allostatic load and how they influence immune responses to a prostate cancer vaccine among men who have a high risk for developing a recurrence of their prostate cancer. Project 2 is working to identify novel biomarkers that can improve the precision of identifying prostate cancers that need to be treated. And we're doing this within the context of understanding the distribution of these biomarkers based on allostatic load and self-reported characteristics and social factors. And then the third project is conducted in the Veterans Health Administration in our VA, the Ralph H. Johnson Veterans Administration here in Charleston, South Carolina, which is to examine the effects of vitamin D supplementation on molecular changes in the prostate among men who are undergoing a prostate biopsy. We implement a standard social determinant survey to understand the nature and distribution of a variety of stressors that exist in terms of socioeconomic characteristics, disease-related variables, and psychosocial and social conditions. And this social determinant survey is implemented and administered to men across all three of our studies, as well as in our pilot work, so that we can understand the ways in which there are similarities and differences in these social determinants among men as they are sort of encountering different critical trajectories within the continuum of prostate cancer diagnosis. The first example of results that I'd like to give you from our Precision Medicine Center are the results from a systems analysis of the prostate transcriptome in African American compared to white men who were undergoing radical prostatectomy in the VA. And what this work showed was that African Americans had higher expression of genes associated with immune response and inflammation compared to white men. And then on a follow-up study, we examined the prostate transcriptome using a single biopsy core, and we're interested in gene expression patterns between African American and white men who had early stage prostate cancer. And what we found was that two genes, specifically PERK and SRP1, related to the endoplasmic reticulum, had a moderately higher expression in African American compared to white men. And so taken together, these two endoplasmic reticulum stress transcripts were suggestive of a greater stress response in African American compared to white men. Now, these findings are important because it's, I think, first evidence showing that there's cellular stress response differences between African American and white men within the context of prostate cancer. But it's also important to think about stress as it can be psychologically manifested. So there's a biological mechanism for stress responses, and there's also a psychological mechanism of stress response. In this next example, which examined physical activity in African American prostate cancer survivors who had been treated with radical prostatectomy at the Hollings Cancer Center, and who were identified from men who had donated a tissue sample as part of donating to our biorepository and tissue analysis core at the Hollings Cancer Center. What we found was that only 34% of men met the recommended guidelines for moderate intensity physical activity, and that that men who had greater perceptions of stress had a lower likelihood of meeting the recommended guidelines for moderate intensity physical activity. Now again, perceived stress is important psychologically because it's one of the psychological mechanisms of a stress for the stress response. It's also an important social determinant of health, and I want to in a few moments begin to segue my talk into social determinants of health. But before doing that, want to talk a little bit about resilience. And one of the things I think is really important about our frameworks and conceptual models of disparities is that we often think about the ways in which minority populations have lower functioning, have poorer outcomes compared to white men. And I think this is because we typically are thinking about differences. And when we think about differences or disparities, we think of one group as doing less than the other group. I think this approach has been really important to help us understand and identify where there are gaps and where resources need to be directed and targeted. At the same time, it's also important for us to understand what enables men to be resilient or to recover from challenges, stressors, and difficulty. So these are data from a study that was published this year that examined the extent to which men, and these men were in our VA sample, reported that they were able to be resilient, that they were able to adapt to challenges, stressors, and difficulties, and that they were able to bounce back from these difficulties. So you can see here that 66% of men said that they were able to adapt from challenges, and 40% said that they were able to bounce back. What's interesting is that allostatic load was greater among men who reported resiliency. So it really raises the question about what types of strategies are men using to adapt and to bounce back or to be resilient, and at what physiological consequence or impact or effect are these efforts having. And it's charging us and challenging us to think about ways that we can help men to be more physiologically effective in their efforts and processes of being resilient or bouncing back or adapting to challenges, stressors, and difficulties. One of the ways that we can do that is, one, to identify men who have unmet social needs. And the idea of identifying and understanding social determinants is now a really important priority nationally, locally, and regionally, because healthcare systems, healthcare providers are now being held accountable and are having greater increased responsibility for understanding their patient's background and developing and implementing strategies to help patients to have better outcomes following their interactions with the healthcare system. And we know that the healthcare system and the clinical settings are critically important. These are the settings in which healthcare is delivered. But people have to follow recommended guidelines. They have to manage their conditions. They have to be compliant with recommendations in the communities or in the social environment in which they live. So more and more professional organizations, national organizations are recommending that social determinants be obtained from patients and documented in their electronic health record. And you can see here that there are many different ways and different types of social determinants that reflect the conditions in which individuals live, learn, work, and age. And all of these things can affect someone's health and well-being and their lifelong health. I think there's several clinical and public health priorities for understanding and addressing social determinants of health. The first one is that because there are many different determinants that are related to the social environment in which people live, work, and age, that we really have to be thoughtful about identifying and documenting social determinants of health using a standardized approach, using validated instruments, and documenting and measuring those that can be actionable within the context of a clinical setting. Relatedly, clinical workflows need to be established to make sure that as patients with unmet social needs are referred appropriately to social services. And then we also lastly have to understand acceptance to social referrals and understand the extent to which referring a patient to a social service organization or to a social service program has a clinical benefit in terms of improving patient outcomes. Our Precision Medicine Center, I think, has been leading the way and developing tools to understand the extent to which social determinants are currently being documented in the electronic health record. And so our data integration core has developed natural language processing tools that can be used to identify and extract data on social determinants of health using the clinical notes. And I think this is a really important and exciting approach because, one, it tells us something about the extent to which patients and providers are talking about their social background. It also tells us something about the extent to which these variables are being documented in the electronic health record, which provides the foundation for us to be able to act upon and intervene among those who have unmet social needs. So one of the natural language processing tools that we developed is related to financial strain, and financial strain is a really important priority within the context of prostate cancer or any type of cancer because cancer treatment can be very expensive. Cancer treatment, several studies have shown that patients who are being treated for any type of cancer experience some sort of financial strain or hardship. And you can see here that financial strain or hardship reflects the extent to which patients have financial hardships because they do not have sufficient resources to cover their expenses. Now, it's exciting time for thinking about social determinants such as financial strain because CMS has now issued guidance about one, that social determinants should be documented. They're creating ICD-10 codes that can be used to document the presence of social determinants or unmet social needs using specific codes and documenting those in the electronic health record. What we've been interested in doing is understanding the concordance between the documentation of of social determinants such as financial strain using the electronic health record based on what's documented in the clinical notes, what's documented using ICD-10 codes, and what's documented by what patients will self-report as an unmet social need. This is one example that I'm showing you now for financial strain, where in our cohort of patients who were treated with radical prostatectomy at the Hollings Cancer Center, none of the patients had an ICD-10 code that could be used to document financial strain, but 6% had financial strain documented in their electronic health record using and were identified using our natural language processing tool, and that 18% self-reported having a financial hardship. So taken together, these findings really demonstrate the importance of using a quality improvement strategy to enhance the ability of healthcare providers to document social determinants with greater precision, using ICD-10 codes, and also using greater precision of documenting these discussions and unmet social needs that are identified through patient-provider communications as part of the clinical encounter in the electronic health record. So this shows you results from our work using with our social isolation lexicon, again using the same approach where we developed a natural language processing tool to identify social isolation, and overall only less than 2% of patients had any instance of social isolation documented in their electronic health record. And what this table is showing you is that there are different types of terms that were used to indicate social isolation and the frequency with which they were documented in their electronic health records. So it ranged from 19.5% for lack of social support to 3.4% for social isolation and feeling isolated. So one point to make with this particular example is that there are many different ways in which providers can and do document a particular social determinant. So one of the areas that I think is really important for us to think about in terms of improving the precision of collecting and documenting social determinants with the greatest precision is that we need to come up with standard terminology and language for how these social determinants are documented in their electronic health records. So some of the key findings from our precision medicine research is that one is that we've generated some, I think, some really exciting findings related to racial differences in molecular stress responses or cellular stress responses. And that's an important biological cellular mechanism that plays a role in the initiation and progression, can play a role in the initiation and progression of disease. At the same time, we've also begun to explore a psychological mechanism for stress responses in terms of perceptions of stress, and demonstrated that men who have greater perceived stress are less likely to meet an important cancer control strategy or strategy for for controlling cancer. We've also demonstrated that there's an opportunity, I think really important opportunities, to work within the space of improving the precision for addressing social determinants data. So really, we're at a point now where there's the power and the investments that have been made to implement electronic health records. There's these investments can be leveraged to understand the nature and distribution of documentation and discussion of social determinants as they are occurring now in patient as part of the clinical encounters. That can be used to develop more structured interventions to improve the quality and precision of documenting those determinants and addressing those unmet social needs using evidence-based approaches. So the last thing I'd like to talk about is work that is being supported by the Duke Endowment, which is really building upon our work with developing natural language processing tools to identify social determinants in a really important way. And so our goal here is to develop, implement, and evaluate what we're calling a multi-level informatics strategy for identifying patients who have unmet social needs based on the extent to which social risk factors are documented in their electronic health record, and using a community-based navigation program to link patients who have unmet social needs with social service organizations and community settings. As part of that, we'll be examining the concordance between social determinants reported by patient self-report and those identified using natural language processing to help us understand the performance and the precision of our natural language processing tools, because ultimately we would like to be able to disseminate those tools to a wider audience, to different types of healthcare settings, so that other institutions can have a better understanding of the distribution of unmet social needs in their patient populations, and use that as the basis for making operational decisions about population health strategy. So social determinants are one of the focal areas of this recently published Cancer Disparities Progress Report that was released by the American Association for Cancer Research. And I wanted to bring this report to the attention of the conference participants, because it really, I think, summarizes much of the substantial progress that has been made in terms of understanding cancer health disparities and identifying the complex ways in which biological, social, psychological, and behavioral characteristics and factors work together to lead to excess rates of morbidity and mortality in racial and ethnic minority groups. It also highlights our vision and the vision for the field, and as part of that helps us to sort of outline several important areas that are future directions for ensuring and achieving the bold vision of health equity for racial and ethnic minorities and individuals from other underserved populations. So I encourage you to seek out this report, because it is an important resource that helps us to understand where we've been, where we are, and I think importantly where we need to go. So if we think about our future directions, one area that I think is really important for us to think about is developing, implementing, and evaluating quality improvement efforts to enhance the collection of data on social determinants of health. And related to that, identifying patients who have unmet social needs is really important, but will only be effective to the extent that those patients are linked with social services in their communities to help them address their particular set of needs. And those efforts need to be coordinated. We know that we have several opportunities to reduce the fragmentation and care coordination in our healthcare system. And so as we think about and develop strategies for collecting and documenting social determinants of health, we also need to develop coordinated approaches to addressing unmet social needs. The other two areas that I think are really important future directions for the field and will really enable us to transform our healthcare systems, which ultimately will enable us to transform, to do more transformational work that has the ability to really move us towards cancer health equity, are translational studies that help us understand the interaction between biology and psychology. I think, really thinking through and using multi-level strategies to address determinants will be critically important to transform our field and our work so that we are able to move towards cancer health equity. So in closing, I'd like to thank, again, the conference organizers for including me in this important conference. I'd like to acknowledge and thank the funders for my research program, and acknowledge my collaborators at the Medical University of South Carolina, the University of Pennsylvania, Hampton University, and the University of Texas San Antonio Health System. Most importantly, I'd really like to acknowledge and thank all of the participants who have been gracious and willing to give of their time and effort to participate in several different types of studies that my research program has been a part of and have led. We really cannot do this work without the active participation of patients and diverse sets of stakeholders in cancer health equity and cancer research that's really effective at reducing disparities. Thank you.
Welcome back. Lisa Heldke, the director of the Nobel Conference here, and I'm just cutting in really quickly to tell you that there is indeed another discussion going on, starting right now, actually, and I didn't exactly give the most precise directions before. Please go to the Nobel Conference webpage or write to the gustavus.edu webpage, and when you click on the link there, you'll be asked